Hi, everyone. My name is Beth Rachlis, and I'm an epidemiologist at ICES. And today I'm going to be talking about the prevalence of blood-borne viral infections among people seeking fertility services in Ontario, Canada. I wanted to start off today by first acknowledging my co-authors, Elisa, Heather, Lisa, and Jeff. And if anybody has any questions, they can reach out to me at the email address. I am going to go ahead and turn off my video and do the rest of the presentation this way. So I'm currently based in Ontario, Canada. So for those of you that don't know, Ontario is Canada's most populated province with 40% of the country's population. And like other parts of Canada, we have a publicly funded healthcare system in Ontario that's mainly run through OHIP, or the Ontario Health Insurance Plan. So eligible individuals have physician visits, hospitalizations, ED visits, ambulatory care, and prescription drugs covered. ICS is an independent, not-for-profit research organization that was established in 1992. It is home to over 200 scientists located at 6 satellite sites across Ontario, and is also designated as a prescribed entity by the Ontario Information and Privacy Commissioner under Ontario's Personal Health Information Protection Act. ICS has numerous data repository, which makes it a great place to work. And the data holdings include information on health services utilization, such as OHIP, as I previously mentioned, clinical registries, population-based health surveys, information on healthcare providers, and electronic medical records. The Ontario Ministry of Health initiated the Applied Health Research Question Program. So basically an ARC, as we like to call them, is a question that is posed by a health system policymaker or provider in order to obtain research evidence to inform planning, policy, and program development that will benefit the entire Ontario health system. ICS is one of the ministry's designated sites to respond to ARCs, and it's a good place to do that because often a lot of the questions involve using the ICS data holdings. So how the process works is that knowledge users submit an ARC request to use the administrative data to inform their health policy planning and program development. So this project that I'm speaking on was an ARC. In order to provide appropriate treatment, such as antiretroviral therapy, individuals undergoing infertility treatment require ongoing testing for blood-borne viral infections. In Canada, there are no standardized testing protocols, and so really testing is often done at the discretion of the physician, but is expected to happen at least annually. At the same time, it's unknown how many tests are being done and how many positive cases are being identified in this process, and so therefore whether the testing guideline needs to be revisited. So an ARC was submitted and was approved by the ICS ARC team, and that is how I became involved. The specific objectives of this project were to determine whether current blood-borne viral infection testing practices are effective for the timely identification of blood-borne and viral infections among individuals who are undergoing fertility services or seeking fertility services. So there were two main objectives. So one was to look at the prevalence of repeat testing for blood-borne and viral infections, and the second was to estimate the blood-borne viral infection incidence rate, mainly for viral hepatitis and HIV, over a 5-year follow-up period. Jumping into the methods, first what we needed to do was to identify individuals who were seeking fertility services. And so we relied on diagnostic codes billed by gynecologists and neurologists between April 1st, 2002 and March 31st, 2013. We were interested in all Ontario residents who were eligible for OHIP and who had at least one hepatitis test within the first year, within 1 year of the first infertility record. And we did this because the knowledge user was actually interested in looking at repeat testing. We also limited our population to individuals who had at least 5 years of follow-up time available. So in this case, they had information at least up to, or we included individuals up to March 31st to look at incidents. Our index date was the date of the first hepatitis test that occurred within 1 year of the first record of infertility. And we say first record and if an individual had multiple consults. The table I provided for you just highlights some of the definitions and codes that we use, as well as the data sources. So I'm just going to say a few things about this. So the first thing is that we used hepatitis tests as a proxy for all blood-borne and viral infection tests. So we didn't have specific information on HIV testing, and this was based, we relied on a fee code submitted by physicians in OHIP. We have a data set at ICS that used a validated algorithm to identify all people in the province of Ontario who were estimated to be living with HIV. And this was based on using 3 physician claims with specific diagnostic codes within a 3-year period. What we didn't have was viral hepatitis diagnoses. So what we decided to do was to use a similar algorithm. So again, 3 visits with the specific diagnostic code within a 3-year period. And what we did is we excluded any codes where an individual may have been getting a vaccination for hepatitis. Finally, we also use a registered persons database to capture our cohort information on eligibility, age, sex, and other covariates that we were interested in. There were two main analyses. So the first was testing. And as I mentioned, the knowledge user was interested in repeat testing. So we calculated the annual prevalence of hepatitis testing, again, using viral hepatitis as a proxy for all blood-borne and viral infections, including HIV. And we looked at each year of follow-up from a first test and then overall cumulatively over a 5-year period, and we stratified that overall by sex. We also looked a little bit more in detail at the number of tests per individuals and the time between tests to capture a little bit more granulated information. The second analysis we performed was looking at incidence. And so here we calculated the incidence of hepatitis, viral hepatitis, mainly hepatitis B and hepatitis C, and HIV separately over a 5-year follow-up period. And again, we looked overall and stratified this by sex. For the secondary analysis, note that we excluded anyone with a known positive HIV or hepatitis diagnoses prior to our index date. So the first results are for testing, and we can see that there were 184,328 individuals who were included, and the majority of them were female. So the table below you has a bunch of different information, but really what I want to focus on is looking at the prevalence of blood-borne and viral infections over the 5-year cumulative period, which was just under 46%. And we can see from the table that the testing prevalence was indeed higher for females. While the data is not shown here, I can tell you that the median number of tests per an individual was 2, but there was approximately 5% of individuals who had 5 or more tests done over the 5-year period, indicating that there was more than 1 test being done over a 1-year period. For incidence, we can see that our cohort size is a little bit smaller, and this is because we excluded the 2,500 individuals who had a previous diagnosis of either viral hepatitis and or HIV. Again, I provided a table that shows the accrued rate and gives you some information on the number diagnosed within 12 months. Over a 5-year period that we looked at, just under 1,000 new viral hepatitis diagnoses were identified with a cumulative incidence of 522 cases per 100,000 population. Just under 50% of these were diagnosed within 12 months of a first blood-borne and viral infection test, and the median time from the first test to a diagnosis was 13 months. We identified just under 60 new HIV diagnoses with a cumulative incidence of 31 cases per 100,000 population. And a higher proportion of these, so 70%, were diagnosed within 12 months of that first test, and the median time from a first test to diagnosis was 3 months. As with any study, particularly study involving administrative data, there are limitations to note. So the first is that we were only able to identify consults for infertility rather than being able to know if an individual went on to actually receive treatment. We used hepatitis testing, I mentioned, as a proxy for all blood-borne and viral infection testing, including HIV. And this was based on the assumption that blood-borne and viral infections would kind of be tested at the same time. So someone might be getting tested for hepatitis and HIV at the same time. Not all hepatitis testing is captured, however, in our administrative data, and tests that occurred in the context of infertility treatment were unable to be distinguished from testing that might be done in other settings. As I mentioned in the methods, we did not have access to the results of the hepatitis testing, so we're unable to know for certain that if a positive test actually resulted in a diagnosis. And the algorithm that we use to identify viral hepatitis has yet to be formally validated. It is work that we are hoping to do, but note that we did exclude all visits associated with vaccinations. Finally, the implications of this work show that people, at least in our setting, who are accessing fertility care are at a relatively low risk for blood-borne and viral infections. Findings can be used to develop evidence-based testing guidelines, which was the aim of this study, for individuals specifically seeking out these services. So we found that testing was conducted more frequently than expected, and in some cases was performed more than once per year. So the results, one option is to make the results of blood-borne and viral infection testing for this population accessible through some sort of an integrated electronic platform to reduce testing redundancy. Given the limitations that I identified, in particular around our inability to capture hepatitis diagnoses, future research is going to work to validate this definition that we created to identify the viral hepatitis in our data by linking hepatitis data available through laboratory data available through Public Health Ontario. I just wanted to acknowledge that this work was supported by ICS, which is funded by an annual grant from the Ontario Ministry of Health and Long-Term Care, and again, to acknowledge my co-authors in this important work. Feel free to reach out to me if you have any questions. Thank you so much.